Okay, welcome everybody. This is the public forum for newborn jaundice awareness, what the public should know, basically. We're still trying to see if we can get some people joining us. We have received quite a number of questions that would be answering. We put up the link on Facebook and other social media handles. We'll start the program with an opening prayer. Shall we pray? Father, Lord, we thank you for this day. We thank you for the opportunity to get together once again and educate the general public and ourselves. We pray that as we begin this meeting, you sit in with us, and we pray that everything that we do becomes successful. We thank you in the name of Jesus Christ, we have prayed. Amen.
Amen.
Hello, can everybody hear me?
Yes, I can hear you.
Hello.
Hello.
Okay, so we have some of our national executives with us, and then I can see that we have some outgoing executives as well. We welcome you all, and we welcome everybody to today's program. We'll start by calling on Dr. Francis Akwete to give us a brief, to tell us why we are here, a brief summary of what we've done, and then we'll open the public forum to answer questions. Okay.
Okay, hello. Hello, can you hear me, please? Hello?
Yes, Francis, we can hear you.
Oh, okay. Good, let's say good evening once again, and thank you for joining us. I think the newborn project, newborn week or month, is a good initiative done by the Pediatric Society of Ghana to make us aware, all of us, sensitize us, even the health workers and even the general public on the dangers of newborn jaundice, the complications and what they can cause. So this whole project started initially from the PSG, the Pediatric Society of Ghana, Greater Accra, started it some years back. Then I think about 3 years ago, 2018, then follow up Ashanti took over, and then now we are trying to make it mega. I think it was last year, it was a bit mega compared to the previous years. So we are trying to reinforce it this year to make the newborn jaundice problem or issue more publicized so that everybody will know about it, so we can reduce the morbidity and mortality caused by neonatal jaundice. So most of the times when the general public, they ask that do even children get jaundice, because most people are associated jaundice with a liver disease or in the elderly. So I think when you bring this up, it will make people aware of the need to pay attention to jaundice in the newborn, especially the first 7 days of the child's life. So I think this is why we are here, and we welcome each and every one of us here. So we'll be answering questions. Any questions you have, you can bring it up for us to deliberate on it. Thank you very much. Once you are welcome. Hello.
Okay, thank you very much, Francis.
Hello, Ifwa.
Yes, thank you very much, Francis. Thank you, everyone.
Okay.
So we have on our panel Dr. Francis Akwete, and then myself, Dr. Ifua Jemfi. We have our pediatric nurse Delali, and then we also have Dr. Panga and Dr. Jocelyn Esibe on the panel. We are ready to answer any questions that the public may have. You can type in your questions in the chat box. You can raise your hand. You'll be called also to talk, or you can send a private message, and then we read out your questions. So these are the people that will be on the board, on our panel. Yes. Does anyone have any questions? Any question to be answered? Any question to be answered?
Hello, I think Desmond Fagekbe's hands is up. Can Desmond, you can unmute yourself and ask your question, please. Desmond.
Hello.
Hello, Desmond.
Yeah, I wanted to know, baby formulas, don't they have any nutrients that prevent this jaundice that we are talking about? Are those nutrients only found in breast milk? That's my question.
Okay. Okay, I think to start with, is it Bright? Oh no, Hilda. Question from Yaunsi. I said, what at all is, this one, I'll come to your question. I mean, let me just answer this one, then we'll come to yours first.
No
okay.
problem.
So what at all is the newborn jaundice, and should we be afraid of it? Then the next from a Bright was, what do I do if my doctor says my baby jaundice is mild? Okay, so we'll answer the first one. That's really more like an introduction to what we are doing. So what at all is newborn jaundice, and should we be afraid of it? So jaundice is basically the yellowing or yellow discoloration of the white of the eyes, or the sclera of the eyes, and also the skin of the babies. And then newborn is the usually first 28 days of life, or first month of life. But usually there's the ones we are mainly worrying about, actually the first 7 days, which are quite critical. So basically the yellowish discoloration of the white or the sclera of the eyes and the skin. So it can be caused by several issues. One, it can be caused, the newborn comes out, the blood, sort of the blood cells or the blood itself is not that so matured, so they can break up easily. So when they break up, some deposits of it or some end products of it can deposit in the eyes and the sclera. Not only that, it can be, that's the outward manifestation, but it can also affect the brain. The reason we are afraid about it is that it can affect the brain. The jaundice which occurs from that point can affect deposits in the brain and can lead to long-term problems like cerebral palsy. It can also even immediately lead to death of the child from other issues. So basically, that's a general overview of it. It can be also caused by, we call it blood group incompatibilities. I'm sure questions will come in on it, but I'll just introduce, maybe when the question comes, then we'll dwell on it deeply. Okay, Ifwa.
Yes, Francis.
Yes, please.
Okay. Yes, I think you tackled that well. Dr. Dano asked the next question. What do I do if my baby Doctor says my baby's jaundice is mild. So yes, there are, for now, if the doctor has done a test and says that your baby's jaundice is mild, it depends on the doctor. Sometimes they'll ask you that, okay, you can go home and continue breastfeeding and then come back for review where the baby's jaundice level will be tested again and then will be seen. But whatever be the case, you are going to be listening to what the doctor is asking you to do. Don't do any other thing aside what they are saying. You are not going to take breast milk to put on the eyes. You are not going to give any herbal preparations. You are not going to give anything. You are just going to listen to the doctor. You are going to breastfeed your baby. If you've been asked to go home and come for review, the most important thing is for you to come for review, especially if the baby is less than 5 days old and you are asked to go home. Sometimes they'll tell you that is mild, but the baby will require that we put the baby under a blue light. If that is required, just listen to your doctor. Get the blue light for as long as it can be done. Do the test that you've been asked to do, and your baby will continue to live well and do well. Okay. All right. Thank you.
Okay, hello. Okay, F1.
Yes.
Okay, I think this one asks about the formula. It's why is that we are emphasizing on breast milk. Actually, for babies or for say human babies, breast milk from the mother is the best. Is the best in all terms. That is natural, is safe. In the case where it's affordable and it's easily accessible for the baby at any time. So another any early initiation of breastfeeding in the case that I said other causes, I wasn't talking about the cause of jaundice. Sometimes I would say dehydration or reduced level of fluid in the child, or I'll say lack of nutrients or food in the child can result in jaundice. So we advocate for early initiation of breast milk in such a case that when a baby is latched on the breast, as soon as the baby is delivered, some have protocol, some say within the first hour, some say the first 30 minutes. That's as soon as possible. Realize that the baby is able to adapt to it, the breast milk is able to flow well. Then also, when the breast milk begins to flow very well, the baby gets enough fluid, enough food, enough nutrients in a case to allow for uh, uh, feeding. And when there's feeding, when there's feeding occurs, the amount of fluid in the child is improved, and also clearing also okay, so the gas movement also occurs. So in that case, you're able to reduce or prevent neonatal jaundice in some extent. So your question was that why is that breast formula? So formula has for the baby at that point is one case. Sometimes the baby how it's even fed the baby can be a problem. Then also sometimes to even the preparation, you prepare it well, if it is so, but sometimes to the baby might not be able to take it appropriately, and also it's not the utmost for the baby. Your question was, do you have anything that why the formula that can prevent it? In actual sense, we don't have anything specifically in the formula to prevent it, but it's the feeding that will help. But in that case, the breast milk is appropriate in, better than the formula. Maybe if I can you chip in here, please.
Yes. So another thing with the formula, we do not advise that a baby takes formula, mainly because it is not easily digested as compared to the breast milk. So most of the time you see that when babies are fed with formula, the gastric emptying time, I mean, the time it takes for feces to form, for it to come out of the baby, it's prolonged. In that case, the little jaundice that has been worked on by some enzymes is now going to go back into the baby's circulation. So clinically, we'll say that we have an enzyme in the baby's intestines, which is very high as compared to adults. when the jaundice that the baby has been worked on, it will go into the bowel, and then it will come out of the body, giving the baby's stools then its normal color. Now, if you feed the baby with formula, the baby is not going to have was not going to go like pass stools as often as a breastfed baby. So you see that the formula is stuck in the baby's intestines for a long time, and it will cause the jaundice that is going to be excreted from the baby's system. It will now be converted back to the jaundice to the bilirubin we are afraid of, and then it will go back into the baby's circulation, making the jaundice worse. So we prefer that the baby, that is part of the reason why we chose the theme this year, that early initiation and then breastfeeding. It actually helps to clear the jaundice. It's better for the baby and is our preferred option. We will only go the formula way if the baby's mother is very ill or for some reason the baby is unable to breastfeed. But formula is not supposed to be given to the babies, especially when they have jaundice. Dr. Sibden,
thank you.
I don't know if they have anything more to say.
Hello. Okay. Then maybe Diana, can you please take the next question? I think the question was what are the treatment options? Okay. Sorry, before that, Desmond, please, are you okay?
Yes, I'm okay. Thank you, Doc.
Okay. 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 Diana, please, can you please take the next question? What are the treatment options for the jaundice, please?
Okay, thank you very much.
Okay. Thank you.
Depends on the underlying cause of the jaundice. Some of them medical treatment, and some would require surgical treatment, but the majority of them would require medical treatment, which is the phototherapy lights. Usually you put them under the blue light, you do the lab test, you monitor the levels until it becomes to a level that you know that will not affect the brain of the baby. So essentially, most of the cases we see can be managed using the blue light. It's just a few cases that may require surgery depending on what is causing it. Yeah, so that's basically it. If you have anything to add.
Okay, so I want to maybe can just talk about people who have the sunlight issue. Can you please touch on it a little?
Okay, all right. So like I said, if a baby has jaundice and then comes to or goes to the hospital, and then whoever says that, oh, go home and continue breastfeeding and put the baby under sunlight, we do not advise that you put the baby under sunlight. So if a baby comes, has jaundice, the best thing to do is, if you go to a health facility where they are not able to manage it, we encourage that they refer to an appropriate facility that would be able to manage the jaundice by either using the light, doing the lab test to monitor the levels. We do not advocate sunlight. We do not advocate putting breast milk into the eyes or any other herbs or anything onto the eyes to help clear the jaundice. So if you go to a health facility and then you are seen and they tell you that, oh, this jaundice is not much, you go and put the baby under early morning sunlight, please, please, please go to a bigger facility where we can do the testing appropriately to be sure that the baby would require the blue light, or the baby can go home safely and come back for lab tests to be done to be sure that the level of the jaundice is not rising to the extent that it can damage the baby's brain. So please, no sunlight, no breast milk treatments, no herbal concoction treatments. The blue light therapy, which is available in some hospitals, will do the trick. Thank you.
Thank you very much. So the next question is, any duration for the clearance of the discoloration, or when should I be worried when improvement or clearance doesn't come. Dr. Sibe, please, can you take this one for us, please? Okay. Yes. If please, can you take this one? I think Dr. Sibe seems not to be on the call.
Okay, I think it's the network.
Oh, okay.
So hello. Yes. So
Hello, Efwa.
yes, for the
Mhm.
duration of clearing, it takes a while for the yellow to completely go from the eyes. I know that is a source of worry for a lot of mothers. They come in and then they say that, oh, okay, so my baby's eyes are still yellow. I've been asked to go home. So it takes a while. I think between 3 to 6 weeks. It will take between 3 to 6 weeks for the yellow discoloration of the eye to completely go away, for you to see the sclera as white. So usually we tell them not to worry so much, but so far as a doctor has checked and your levels are below the phototherapy levels, that it doesn't require hospital treatment, then you should be reassured that it is okay, and then you can just wait between 3 to 6 weeks for it to completely clear from the eyes. There are some babies whose eyes will be clear. They clear before they are discharged from the hospital. There are others that will stay for quite a while before it goes away. But so far as a doctor is checking and is making everything, then sorry about the noise, then you know that everything is okay. So you should be assured that your baby is doing well.
Okay. Thank you very much. Okay, so hello. Okay. Hello.
Yes, Francis, please, we can hear you.
Okay, I think I'll say okay. So the next question was at what point or days do we classify jaundice as detrimental to the baby? Then can a ritual mother breastfeed a child with jaundice? So I'll take the last one. I'll go to the other one. So can a ritual mother breastfeed a child with jaundice? Yes, definitely. A ritual a mother who is HIV positive, yes, definitely can breastfeed the child. So far as it's definitely breast milk is safe when I don't call it safe for the baby at this point. The mother will do exclusive breastfeeding. There'll be no, the mother is on the HIV medications. The baby is also put on prophylaxis. That's medications to prevent him or her from getting the exclusive breastfeeding, not adding water, not adding any other feed to it. 6 months, then complementary phase and breastfeed up to 1 year. And during those periods, we test the baby as appropriately. So a mother who is HIV positive, adult is not contraindicated for her to breastfeed a child, and it's safe so far as she adhere to all these things that are necessary. So she can definitely breastfeed a child with jaundice. So what point or days do we classify jaundice as detrimental to the baby? So when a child is born, when you notice jaundice on the first day is almost always dangerous. Almost always dangerous. Then we have various levels that we look at. We have charts, though it's not utmost that the chart is foolproof, but it gives us a guide to know how to go ahead. Then also a child who is very sick and has jaundice is at that point it's definitely that jaundice is dangerous for the child. So you cannot just see a child who is yellow and say that, oh, this yellow is light. We can say that maybe if the jaundice is up to the feet, the sole of the feet, definitely we can say that jaundice is dangerous. That means the level could be very high. But that one too, you cannot just look at the child's eyes. So that this jaundice is very deep, this jaundice is light yellow, or whatever, to say that this level. But we can test various ways of testing to know the level. So we compare the child's age in days or weeks, days basically, and maybe the gestational age to say that it's dangerous. But any jaundice on the first day of life, jaundice in a sick child, jaundice the sole of the feet is very dangerous. But we also need the levels to be sure. Then the next question was, what levels are required to be met prior to discharge? So depending on the age of the child, the level of the jaundice, and you have to look at the child in totality, whether the child is well, before we can say that the child is safe to be discharged. So if for any contributions there, or we should move on, please.
Yeah, please, I want to add something.
Okay. Then
yeah. So in addition to what Francis has said, what it points out is to the fact that if your baby has jaundice, it's better to go to the hospital and then let them consider the factors that may cause the jaundice and then decide what can be done. Thank you.
Thank you very much. Great point. So the next question, can babies be put, okay, continue for please.
No, Francis, go ahead. I think I was going ahead. Okay. So.
Okay. Can babies be formula fed if lactation is not well established within the first 3 days? Let me see, please. Okay. So for this one, Dr. can you please take this one for us? Can babies be put on top up formula?
Yes. So basically,
if that is not well established,
this issue keeps cropping up every now and then, because we keep getting worried about how much breast milk a mother should produce. Now, it is normal if on day 3 mothers are really not lactating so much, but that is how come we encourage the early initiation. That is the most important part. So far as we initiate early at birth, then we know that within the first 3 days, most mothers will start lactating. And we don't need 100 ml of breast milk. We don't need a cup full of breast milk. The colostrum alone is enough. Colostrum has some properties that will peg the baby for us. So if on day 3, most mothers will be able, they'll say that, oh, I don't have any breast milk. But if you are able to help them squeeze out something, you see that they do have breast milk. It's just that it is not as much as we are looking out for. So yes, that small one that is coming, the very first one that we are looking out for, the colostrum, is enough to peg the baby to ensure that all the meconium and other things that are in the gut has been cleared, leaving it free. And as soon as you have your colostrum coming, you know that the follow-up, you are going to get more milk coming up afterwards. Now, especially for the CS, for the mothers who have undergone CS, it takes a while, mainly because we usually are not on top of our pain management. But if you are able to take the pain away by being on top of our game for the pain, you see that they would also start, and if you are able to initiate breastfeeding within the first hour of birth, they would also start lactating earlier on than necessary. And remember that at day 3, we are not looking out for a lot of breast milk. Of course, there are mothers who will lactate earlier. The veterans would also get a lot of breast milk coming in, and sometimes you are surprised. We are all different individuals, but note that you are not looking out for a lot of breast milk. Just a little bit is enough on day 3. And do not start giving formula. As soon as you give a baby formula with at day 3, or even day 1 or day 2, it means that they are going to be full. They will not suck when you put the breast to the mouth because they are full. And without that reflex action taking place, there's no way the mother is going to produce enough breast milk. So you are just going to prolong the actual lactation that you are waiting for. Giving formula distorts the whole reflexes that we expect to happen in a new mother who has to lactate. So let us be cautious. Let us assist the mothers in trying to get the colostrum to come, and then let's be patient. Let's continue to put the babies to breast. And you see that usually on day 3, day 4, a lot of the mothers will start producing just enough to cater for the baby. Thank you, Francis. Hello. Hello. Hello.
We are listening.
Yeah, we are.
Okay, all right. For a moment, I thought no one could hear me. Okay, so unless someone wants to, Diana, would you like to add something to that?
Oh, no, I think that's fine. All I think they should keep in mind is that the more the baby suckles onto the breast, the more breast milk will be produced. So it's very important. Thank you.
Please, the question I was about to ask was what you said, but I'm a male midwife. Formerly at Kenkenso Government Hospital, but now I've been posted to Fuku Municipal. My name is Frank Amuate. The problem I was having with the client was that about 4 days, the breast milk was not flowing. We hardly get it. So the child started developing this jaundice. So it was a problem for me. If in case what should we do so that the jaundice will not appear? That's the question I want to ask.
Okay. So Frank, keep up work. So usually we would not, yes, individuals are different. There are some mothers who will not be able to produce breast milk at all. And then we have those who will be able to produce more breast milk. But then the question is, this mother not, did she even start lactating at all?
No. It was, she was
before.
Yes.
So basically, when a baby develops jaundice, we know that you have to do your test, you run your labs, and then you start phototherapy. You can pass an IV line and then run your IV to also all help with the treatment. Whilst we continue to wait for the breast milk to come. We do not encourage the formula feeding because whatever jaundice you have, adding formula to it will make it worse.
Okay.
Yes. Adding the formula to it will cause the child to, in quotes, have reduced bowel movements or some form of constipation. And that is what we do not want. Because all that work that our treatments, our phototherapy is doing for us, we need it to clear without the so therefore, it's still not too late. Mother can still put the baby to breast. You start your phototherapy, you set up your IV line to ensure that baby is being hydrated and all. And I'm sure that the mother will do well on that. And then we need to continue to counsel the mothers. We need, you see, when a mother gets worried, when a mother is in pain, when a mother is stressed, then she's not going to get enough breast milk. So what we usually ask the mothers is that we need to talk to the mothers. We need to let them understand that this is not the first time that you have the doesn't have any breast milk. Let's talk to the mothers. Let's talk to them, understand what is going on. Let them know that the breast milk helps, that also are offering treatments
and then it makes it easier to treat both mother and then the baby. And we make sure that we are taking care of their pain and they are not really stressed as well.
Okay, thank you very much. I think my network was also, I lost some of the questions, so maybe you can look at them and see. I can remember one question. Let me see. Somebody asked about was there at any point in time that a child 3 months old can have jaundice? That's a question I can remember. But I think we can also, let me just answer this one. Then we'll look at other ones too. So jaundice. Hello.
Yes, we can.
Okay. Okay, I'm getting the feedback. That's why. Okay. Okay, a child at 3 months old can get jaundice. Because jaundice, as I said, can be caused by several factors. Can be due to maybe, as I said, the blood breaking too much. Can be due to an infection. Can be due to we call it obstruction of the flow of. Hello.
Hello.
I'm getting the feedback from the background. Maybe let me see. Okay, can others mute, please? Come hear the feedback. Okay, so from obstructive cause, like maybe there's the gallbladder, there's a problem with the gallbladder, or maybe there's a liver disease that can also cause jaundice. So jaundice can occur also at 3 months old. But the main talk here is mainly about the neonatal period. That's the first 1 month of life. That's the 28 days of life. So jaundice can occur anytime in a person's life. That's what I want to say there. So can you please look at other questions in the chat? I lost them because my network went off. Okay, I think Margaret.
Okay, I'm thinking.
Please, can we mute our mics? There's a lot of feedback. Okay.
Okay, I've seen some questions here from the chat. From Galaxy 8 and to everyone says that thank you very much for the knowledge on the sunbath issue. But practically in instances where this delivery was done in a health center or a CHIP zone and a midwife advised on sunbath, should the mother disregard the advice and proceed to a bigger facility? Yeah, so I'll just take this one. So we do advise that if your baby has jaundice and you've been advised to do the sunbath, it's better for you to go to a health facility where they can actually do the lab test. And if the child requires some light, they'll put the child under the phototherapy light. Because we've had instances where babies have been told to go and do sunbaths. They come back and the level of jaundice has been so bad that their brains were essentially destroyed. Some of them even died. So in order to keep some of these few issues from coming up, it's better that you go to a health facility that can do the test and that can provide the light for the baby as well. Another one says that why blue light for the therapy and not any other color of light? So the blue light, so the phototherapy the light is sort of in the blue range, and it's what has been shown to be able to break down that wanted jaundice in the baby into a form that can be brought out from the baby's system. So that's why the blue light is used and not any other kind of light. Francis, I think there are a few, I don't know if you want me to read them out for you or if what to tackle them.
You can. Yes, I think I read them out.
Okay, so the next one says that how often should a jaundice baby be tested for bilirubin levels when undergoing phototherapy management? Francis, I don't know if you want to take this one or if what.
Okay, so I'll just take this one. It's when I look at the NIS, that's the NIS are putting the full name, but the guideline from the UK. they actually have various ways. Some depending on the courses. Actually, it depends on the course. Basically, every 4 some go 6 hourly. It's after like that. It's after the jaundice coming down. It can also rebound. It can come up. What happens is that the jaundice or the bilirubin in the system is being transformed into a form, a type that can be easily excreted through urine. That occurs. Other things occur so that the production of bilirubin is also increased. So we sometimes some advocate that every 6 hours we check the bilirubin levels to be sure. But you know that in our facilities it might be difficult to do that. So some go for every day, or some also look at the clinical picture of the child and see and go for it. So it actually depends on the child you are managing. The child in front of you determines how you go about it, and the access to all the other facilities. But naturally, the guideline from the UK one I saw recently gave us 6 hourly. But you know, our system might be different, and also depending on the child in front of us. So that's what I'll go with that. Thank you.
Thank you. So the next question from the chat box says that this is from Galaxy A10. Please, in cases that we are managing PPH, that is postpartum hemorrhage mother, who might not be able to initiate early breastfeeding, what next step should we take? If I would you want to take this?
Okay, so if there's, so like we said earlier on, if the mother is unwell, critically ill in the ICU, or the mother is not present at all, then in the first few days we can start on, if you know that the mother is going to get better in a couple of days, like first 2 or 3 days, and wait for the mother to get better. But then if the mother is deceased or is an abandoned baby, PPH, eclampsia, you know they are not coming in well, yes, then those ones you have a clinical indication to start feeding with formula, but not in a rush, especially if you have very bad jaundice, the levels are too high, almost exchange levels. You don't want to rush to go and start formula feeds for this baby. A baby can do well on IV fluids alone for the first 3 days. For the first 2 days, it's okay. But then you can start formula if you do not have any indication that this baby is going to get severe jaundice or in any other way. By all means, this baby has to eat. So yes, it depends. You have to pick it on individual basis. We are not condemning formula feeds totally. Yes, there are indications when the mother is not available and you have to give formula feeds. But then note that if the mother can get well in the first few days, then don't rush to go and start IV formula. You can give IV fluids and wait for the mother to recover, and then you can start initiation as well.
Okay, thank you very much. I think this question answers Margaret Frimpong's question too, in a way. Or any, what do you want to add to it, please? I think her question is, please, in the case we are managing severe jaundice in a neonate at the NICU, and the mother is not producing enough breast milk, what do we do? I think this sort of answers that one also. Let me see any other question. I think that's any other question, please. I think, or did I miss any question from the chat?
I think there is a hand up.
Okay, let me see. Okay, Betty, please unmute yourself and ask your question, please.
Hello, good evening.
Hello, good evening.
Yeah, I'm Betty. I want to ask that in managing of severe neonatal jaundice, and baby is being less under phototherapy, if baby starts becoming bronze, that the skin color starts changes, please, what is the next step?
Okay, thank you very much.
Okay.
Please, can I take that question?
Hello. Yes, yeah, take it, please. Take it out.
Okay. Please, I'm Anita Chenebo. For babies that turn bronze under the phototherapy, usually what happens is that the bilirubin is usually the direct or the conjugated bilirubin. It's not the unconjugated one. So anytime a baby has a conjugated hyperbilirubinemia, the baby tends to turn bronze under the phototherapy. So you have to investigate other causes. It could be cholecystitis or a biliary atresia or something other than the normal jaundice that we know. Thank you.
Thank you. Thank you. Thank you. If please, you want to add anything to it?
Yes, and then there are certain times to when babies are kept under the phototherapy machine for too long a time. I remember I visited one facility and the baby had been under the photo lights for 2 weeks, going on 3 weeks. So sometimes when all the unconjugated has been conjugated and is there and the baby is still under the photo unit, then the baby can become bronze. What do you do when you realize that a baby is bronze? So the first one is to investigate further, like Dr. Trinibua said, if it's any other cause. But your number one is to take the baby out of the phototherapy machine, because they know that the baby does not need phototherapy at that point, has had enough of the phototherapy. So take the baby out of it, keep the baby with the mother, investigate the cause. Then you are in a facility where you cannot investigate further, we would say that you should refer to a higher facility.
I don't understand what thank you.
You should refer to a higher facility or talk to any pediatrician you know who can be able to assist you, and then or a facility that can do further investigation to find out exactly what the problem is.
Okay, thank you very much. The next question from Delali Sepen.
Please, I'm a nurse, so I'm not a doctor.
Okay. Okay, sorry. Can a normal blood transfusion be given to a baby who needs exchange transfusion but does not want to go on referral? Will it be of any help? So what exchange blood transfusion seeks to do is, one, you are sort of diluting the baby's blood, which contains the direct bilirubin, so that you can reduce the level. So it's like if you have hot water and cold water, and maybe you want to bath a baby, you take sometimes sort of try to reduce the intensity or the hotness of the water. You pour some people do this. Some people pour the hot water, pour some cold water in, pour the hot add the cold water, pour the mixture out. So in that case, you are trying to give things transfusion. You are sort of like changing the baby's blood twice. In that case, to reduce the level of the jaundice as much as possible. So that's the main essence of the exchange blood transfusion. That's for double exchange blood transfusion. For the normal transfusion, so first of all, you have to know what are the indications for the child being transfused. Is a transfusion being done for the baby because of the bilirubin levels, or is it because the child is anemic? That's what you have to think about. Or is there any other indication for the blood transfusion? Because if you just blood transfusion because the child is jaundice, you might not achieve that purpose of reducing the level of bilirubin as much as possible. So that's what I would add to that. Then can you please add to it, or if you have any contribution there?
Francis, I think you've basically said it. Yeah. So I think that's fine.
Okay. So next question, is it advisable to treat the fever first or to start with the photo? Okay, there's a question. I don't get that point clearly. Some jaundice baby are hyperthermic on arrival. Okay, so the leading question goes, is it advisable to treat the fever first or to start with the photo management? So to this, I would say that it depends on what the child is coming for, what the level of the temperature is, and what the level of the jaundice is.
So it depends on the child that's in front of you. You manage as appropriate. But I can say that both of them can be done concurrently. The child can be, depending on what fever can be caused, or hyperthermia can be caused by several things. Could be overwrapped. It could be that the child has an infection. It could be that's neonatal sepsis, or it could be that the child was under the radiant trauma or any source of heat for a longer period of time. So depending on what you have, you manage. But I think both of them can be done concurrently. By managing because the child has neonatal sepsis, you can be managing with antibiotics, and the child can be under phototherapy at the same time. So that's what I want to say to that. Dr. Jenfi, can you please take the next one? So why do some babies develop rash sometime under the phototherapy?
Okay. Thank you. So yes, sometimes some of the babies, the phototherapy is sort of an energy wave. It produces a lot of heat as well in there. So yes, sometimes you have some of your you have the baby reacting to it, sort of a miliary rash on there. So when they develop it, it's not something that's, it's not sort of a viral infection or anything. It's just the body reacting to the excess heat that is being produced. And so when it happens like that, we just have to continue doing our antiseptic wash or bath, and then just observe. Just look at them, ensure that they are not too hot, continue checking their temperature, and then it will go away as soon as it comes. It's nothing to be worried about, basically. So it's just that when they have the rash, you need to put in measures to ensure that it doesn't become infected. So just your antiseptic thing, and then it will go away once the baby is taken out of the phototherapy machine.
Thank you very much. Dr. Panga, please can you take this one? And please, what are the contraindications to phototherapy?
Hello, thank you very much, Francis. So generally, we do have a few contraindications to phototherapy. They are usually very rare and uncommon cases. One of which is porphyrias. It's not very common. So generally, most babies are put under phototherapy unless you have a history that there's a family history of porphyria in the family. But really, we have very, very few contraindications to phototherapy.
Thank you.
Thank you.
Then the next question is, how do you manage an 8-year-old and an 8-day-old otherwise well baby, no fever, breastfeeding well, with jaundice, total bilirubin of 376? Okay, so this question, first of all, you have to even know the gestational age at which the baby was born. That's one thing, because it's critical. Because if it's a preterm, and even this value, I've seen this charts for a long time, so I can say this value of about, you need a chart to be sure what level you are dealing with. You need the gestational age to use and compare to the chart and see whether it's high or not. Because if the child is a preterm, the preterm's brain is not as matured as the term baby at this age. Naturally, we often will say that a baby who is after 7 days, and after 7 days is not at risk of kernicterus. That's the bilirubin entering into the brain. But you never know that child who is in front of you. It depends on what or other problem the child will be having. If it's a preterm, you never know. So that one, it depends on what you are managing. I cannot directly say that you do this or not. It depends on what the child you are managing. That's how I answer that question, please. Marianne. That's how I answer the question. It depends on the gestational age. If it's a preterm, you need to use the chart. You can just, it's not advisable to just use the value of it and say what you do. Then the next question, any contributions, please, Dr. Jenfi and Diana, to that question.
No, I think
no, please, Francis. I think I'm okay.
Okay. Dr. Jenfi, can you please take this one, please? When is IV immunoglobulin given?
Yes, so it's part of it's also a way of treating neonatal jaundice. You can do the phototherapy, we have the exchange transfusion, and then we have the IV immunoglobulin. Unfortunately, it's not available in our part of the world. It's done in advanced countries, and that is when you are suspecting, ABO incompatibility. You expect that it is an antigen antibody complexes that are on your red blood cell, and so when you are giving the immunoglobulin, it's supposed to try and help prevent more antigen antibody complexes being formed on the red cell so that they will not be destroyed. Unfortunately, I'm not too sure if the teaching hospitals or REG is using IV immunoglobulin as a modality for managing neonatal jaundice. But for here, what I know we have is the phototherapy machine and exchange transfusion. I'm not sure if any of the facilities is using the Billy blankets. That's also another way. There's this new blankets that you wrap around the baby, and it emits the light within the energy level that we are looking for, just like Dr. Panga said earlier. But I'm not sure about the use of IV immunoglobulin here in our part of the world. But it's also a treatment option for neonatal jaundice, more especially when you are suspecting that it is an ABO, it is an antigen antibody complex that is causing your jaundice.
Okay, thank you very much. I think I know some I've not seen it being used for neonatal jaundice before, but I've seen it used for other conditions basically, but not for the neonatal jaundice. I've seen. Okay, so I think the next question was babies born to GCSPD food defect mothers. How long would you advise these babies undergo prophylactic food therapy? So this question, before, let me just give some few things here. So GCSP food defects, GCSP basically is more like a covering of the okay, let me first of all come to this. We have risk factors of a child developing jaundice. So if the child has GCSPD food defect, it's more like an enzyme deficiency. So that's one. If you have, she mentioned something earlier, ABO incompatibility. So one, if the mother is, let's say, has a blood group of O, and the father has A or B, and when the child is born, the child has A or B blood group, there's a risk of the child's blood reacting to the mother's blood to cause a reaction to cause jaundice. And that's when you have the so-called resource incompatibility. So one, if maybe the mother has a negative blood group, maybe O negative, A negative, or any of the blood group which is negative, resource negative, and the partner has a positive blood group, when the baby is born and the baby basically has baby definitely have a positive, there will be a possible reaction in that case of the blood of the baby, which will cause jaundice. And that one is even the more severe ones. Basically, the resource incompatibility is the more severe ones. So this question about babies born to GCSPD food defect mothers, how long would you advise these babies undergo prophylactic food therapy? So one you have to test the baby to be sure that the baby has GCSPD food defect or GCSPD defect in the first case, because if you do it, if there's no need for it, it's not. You have to be sure that the baby has to be happened before you do it. And with good food therapy, if there's indication, and indications for the prophylaxis, there's some controversies about it. But basically, for if the child has a jaundice with a level that is high enough, or has indication, or there are other clinical indications to it, that's where we go for the phototherapy. But then, if I can please add to this, the prophylactic phototherapy for GCSPD food defect mothers.
Yeah, so thank you, Francis. So essentially, you need to test the baby to know whether the baby does have GCSPD food defect or not. And also, even though most of them are likely to become jaundice, we still have some of them who end up not getting jaundice, even though their risk is higher. So if you consider other factors in addition to blood grouping, resource, and all that, and you think that the risk is high in addition to the G6PD, you can go ahead and decide to do prophylactic phototherapy. But most of them would come in obviously jaundice and would need some phototherapy. So really, it depends on a lot of clinical judgments as well. Thank you.
Thank you very much. I think you've answered please, is immunoglobulin available in Ghana? Is it affordable? Actually, for the other ones I've seen, they've used it for this Kawasaki disease, and that one is it's unfortunately it's quite expensive. I think 1 gram or 6,000 Ghana cedis. But I don't know. I've not seen it being used for neonatal jaundice, but I've seen it used for Kawasaki disease, and that one is also about 6,000 Ghana cedis for 1 gram. But I think every pharmacy has its own cost. That was in Kumasi when I checked. Okay. Please, is there any instruction on the phototherapy machine to regulate the brightness of the lights? Dr. Jenfi, can you please take this one?
So we have different brands and models of machines that are available. Using is not so much as the brightness of the lights, but the wavelength with which the lights is being given. So many a times you even have your lights, but it doesn't work. So the baby will be there 2 weeks, then nothing is happening because the light doesn't work. So even though the light will be nice blue, very nice blue, but then you realize that when you put the baby under that light, it doesn't work. So it's not the brightness of the light, but when you are giving phototherapy, what you are looking out for is the distance between the baby and then the lights. If you want to do intense phototherapy, you have a distance, the baby will be closer to the lights than necessary, if you want minimal phototherapy to be given. And also now that we have the double sided phototherapy machines, it has made everything a bit easier. You have some light coming from the bottom and then some light coming from the top. And also with the billy blankets that is wrapped all around the baby, you don't worry so much about it. But when you are giving phototherapy, the brightness is not the most important thing. It is the distance between the baby and the lights, and also whether the light itself is being is emitting the actual wavelength necessary to treat the baby. So it is advisable for every facility that actually has phototherapy machine to get a light meter. The light meter is what we use to detect the wavelength that the particular machine has. There are different machines that are available. If you have machines such as the Drager machine, and then other cycle, and it's usually written boldly and is attached to a part of the screen where the light is coming from. That's after maybe 2,000 cycles, you should change the bulb. That's one. After each cycle, you see that the numbers keep changing. So as soon as it changes, and then it gets finished. That bulb, if you don't change the bulb, it doesn't have the wavelength, it doesn't have the energy that will treat the child. And so you need to ensure that you have a light meter that is checking whether that is coming in. Thank you, Francis. I'm not sure. My network was going and coming. Should I take it?
Let me see. Maybe just the last point you said. The last point you mentioned. I think it wasn't clear. About, I think you mentioned that every facility have a light.
So I was saying that. Every machine, every phototherapy machine has its how it works. And so for some of the machines, after going a second cycle, you need to change the bulbs. Especially that goes with the Drager. If you have a Drager phototherapy machine at your end, you realize that it is pasted, the overhead shelf where the light comes from. You have something that is pasted on it, almost as if it's a tag or a coupon that has been attached to that part. And it tells you whether this machine is the kind that needs a bulb change. So those ones, after
going through a certain cycle. Some bigger machines will go usually 5,000 cycles. It's either 4,000 for the older versions and then 5,000 for the newer versions. After the cycle, it has the numbers. As you keep switching the bulb on and off, you see that it will be moving from 1,000 to 1,200 to 3,000. As soon as it gets to 4,000, it doesn't work anymore, and you need to change the bulb. Then we have other machines. Some are from China, some are also from Vietnam. Those ones they will tell you that after a certain number of hours, so after say 52 hours or after 120 hours, you need to change the bulb. Then we have things like the Firefly that will say that after being on every second of every day for say 5 years, you need to get the team coming in to change your bulb for you. So that is how it works. But all the same, every technician in every hospital should have a light meter. The light meter is what we use to actually check the actual wavelength, the energy level that the light is emitting. That is the actual thing that treats the jaundice. That is causing, that is the treatment for you. So if you have a bulb without the energy, the good energy level that we want, then you see that you put the baby under your phototherapy machine. After several days, nothing is happening. But then you have another newer machine, you put the baby there, and in a few hours, the baby's jaundice is clearing. So that is one way of knowing that your machine doesn't work and needs a bulb change. Then you change the bulb. Yes. So for the other facilities, other smaller facilities, the health centers and other places who use the normal blue light, fluorescent lights that we get from town. You know, the carpenter has made a thing for you, and then you need to buy a blue fluorescent light. What we usually advise is, if you don't have the light meter, then after you have put a baby under that light, every new baby should buy a new fluorescent bulb. At least that way you are sure that you are getting some form of energy for that baby. Other than that, with the ones that the carpenters make, after using it for one baby, say 6 hours, the energy that is emitting is not the best anymore. So in giving phototherapy, you don't worry about how bright the light is, but whether it is giving the energy. And the energy is measured by the light meter. Or clinically, if you put the child in there and the child is not getting better, you know that your machine is not working.
Okay, thank you very much. I think we are farmers, but I think Victoria Afra, I had her for a long time. Then we'll take from Joshua, then we'll move on to the next stage. Victoria, please.
Okay, good evening. Please, my question is on exchange blood transfusion. Please, when you are doing the exchange blood transfusion, you do the out first before the in. When you push in, how long should we wait before you withdraw? And because sometimes you see people pushing, then without wasting just a few minutes, then they withdraw. So I want to know the standard one. How long should you wait when you push in before you withdraw? And then how long should the whole cycle take? And sometimes we use 10 ml syringe or 20. Which one is preferable? 10 or 20 ml syringe? Thank you.
Thank you very much. Diana, can you take this one for us?
Okay, thank you very much, Victoria, for your question. So for exchange blood transfusion, ideally, as Francis explained earlier, the longer you allow for the mixing of the blood you are introducing with that of the baby's blood, the more effective it's going to be, in that you will be able to take out a lot of the blood that has been contaminated with bilirubin. So preferably 5-minute intervals is preferred, but you should also bear in mind that the bigger your syringe, the larger your volume of blood you are sending in and drawing out. So the smaller it is, the shorter the duration most likely. The bigger volume you are introducing, you need a longer period of time. So roughly with 5 minutes shouldn't be so bad, okay? And also, I personally have not used a 20 ml syringe before, because sometimes it's very difficult to push and draw out. The biggest I've used is 10 mils. So if you think you can push in 20 mils, but carefully and gently of blood, you need to wait for, even I'm sure you would have to wait about 10 minutes because that's quite a lot of blood you are pushing into the baby system. So you need to allow ample amount of time for the mixing to occur so that when you are drawing, you are sure that you are drawing blood that has bilirubin in it. The other thing you have to factor in, which you asked, was the total duration of the exchange transfusion. So most of the time, if you are even doing a normal blood transfusion, we usually do not want it to exceed about 4 hours, if I'm right. So you factor in that period of time, 4 hours, 4 to 6 hours, of which you do not expect, you don't want the blood to get old. So you need to work within that period as well. But in as much as you are working within that period, you need to allow good time for you to be able to mix the good blood with the blood with bilirubin, so that when you are drawing out at the long run, you are sure that you've drawn out as much bilirubin as possible. I don't know if that answers your question, Victoria.
Yes, thank you very much.
You're welcome.
Thank you very much. So I'll take the last one from Joshua Azungu.
Hello. Yeah, hello. Yeah, good evening. Thanks so much for the opportunity. I want to find out, my case is not
Hello,
clinical,
Joshua.
but yeah, hello. Yeah, my
Hello,
issue is that
continue.
in my hospital, we have several therapy machines that are down because of fused bulbs. So I want to link up and see if you have technical men, you can let us contact them to see how they can work on them, because our engineer has actually searched but couldn't get the specific bulbs, so that our machines can be back to use to help these little ones. Thank you so much.
Thank you very much. Dr. Jeffrey, do you have any links with any engineers?
No, we have
the
a facility engineer, but he couldn't make it for us.
Yeah, Dr. Jeffrey, yes.
For the light meter, I think there's an engineer at police hospital. I don't know. He has been to our facility for some time. He said he was going to get the I think he's been visiting a lot of facilities. That's what he said. But he's one of the engineers at the police hospital. He said he has something that will be able to measure it, a light meter or something. So we needed to check ours, but eventually we realized that our light wasn't even, our Drager machine was faulty. So we don't know. For now, the ones that we have are working. So we don't, but the ones that we called him to come, so and look, eventually wasn't working at all. So, but then I know that there's a...
Okay. Hello, Jennifer. Yeah, yes. Breaking.
And then I would like to also add on something. Please, can you hear me? Am I breaking up? I'd like to add on.
It's okay now.
Okay. So what we usually would prefer is that we know that a lot of the machines that we have in our district hospitals and in our health centers are not the best. And like I said, the ones the carpenters make, and in fact, the truth is that it doesn't work. The baby will be there, and usually by the time they are referring to us, you see that the babies are either they either have connected errors or they are worse off. The thing is, jaundice is best treated early. So if you know your machine doesn't work, then you need to refer to a higher facility as fast as you can. But then I would say that as child health advocates, since we are all at the NICU, let's advocate for our medical directors and then our medical superintendents to at least get one very good unit for the facility. I know that getting a good machine can last you 2 to 5 years. So you know that you don't need to worry so much, and then you can manage some of these cases yourself. And then we need to like, let's take opportunity when we are having our Jaundice Awareness Month to actually get the public, the general public, when we go to the radio stations, to ask them to come and donate something to us. Let's get people to know the depth of the issue and how soon we and that we can do something about it. A lot of mothers have experiences. We can call some of the mothers in to help us with our program so that we can raise funds. If the hospital is not getting it for you, can the community get a machine for you to save the children or the babies in that particular community? I think it will go a long way to help us make everything better. And then I wanted to add on to what Dinah also said. When it comes to how much you are pushing in, it depends also on the gestational age. Is it a preterm? How preterm is the preterm? Is it a term baby? Do you get it? You cannot use, say, 10 mils for someone who weighs like, say, 1.2 or 1.5. So it actually depends on who, and is the clinician. You have to bear it in mind that, okay, this baby is small. This small baby, what is the total volume of blood that you are going to exchange, and how long are you going to do it for? You know that the younger the baby is, the more cautious you should be. So you are going to use like smaller aliquots depending on how small the baby is, the gestational age, and how well the baby is as well. So it's always good to have, if you don't have any pediatrician at your end, then it's always good to have a pediatrician at like a phone call away, who can also guide you. And we should know that a pediatric nurse or a doctor, just make sure that you are talking to someone who is well abreast and can help you to actually do it from a distance as well if you have to. We can I also wanted to add that let's do the best that we can. This week is health promotion week as well. Let's utilize it. We have all these health promotion people coming to us to help them celebrate and all. Let us put all our resources together. Let's get them to actually make a lot of noise and see if we can get machines at our end, if we can get help to get some of these things. And for the facilities that do not have, we have ways of checking the jaundice level. It's either you are using the jaundice meter or the lab. If your facility does not have the lab equipment to run the test, then please refer the patient to a place where they have the lab to run the test for you. Not everybody has a jaundice meter. It's very expensive and it's very fragile as well. So please, and know that even if you have a jaundice meter at your facility, when you test, after putting the baby under the machine, it's always difficult to know exactly where you are with the jaundice meter alone. You need the lab to run your test for you again, unless you are covering a place where you'll be checking after the baby has gone under the machine. All the same, let us all try and talk to the pediatricians in our various regions, get their numbers so that you can talk to them, and then they can guide you on how to handle some of these cases that come your way.
Okay, thank you very much. I think to wrap up, I think it's becoming more technical. So I'm sure some people on the platform might be just clarify a few things. So one, conjugated and unconjugated. Basically, we have two types of jaundice. And the one that's usually afraid about mainly, though other causes are also very dangerous, but mainly the one we are afraid about mainly is the one which is we call the indirect one. And that one, so it can can enter the brain and cause something we call kernicterus. That can cause the child to have seizures, convulsions. The child can be so weak, the child might not be able to feed well. Then later on in life, it can cause, the child can die in a few days, or the child can have brain problems. So the child later on might have cerebral palsy, later on might not be able to walk on time, might not be able to feed by itself, might have other complications in life. So that's one of the main reasons why we are afraid about neonatal jaundice. It is deadly and it's also debilitates the livelihood of the child. And it's later on are also affected in some way or not. So that's what I want to add here. So a lot of questions coming in. Some also ask, can jaundice baby be asked to send home, or do we need to do phototherapy for all babies? It depends on the level that the baby has. Sometimes it depends on what the clinician sees, what the child, baby presents with. So definitely, if you have a child with jaundice, please rush the child to the hospital. For the, I want to say again, for the first 7 days of life of a baby, please let's always check the eyes. Check the baby whether the child's eyes are yellow. If you see anything that you are not comfortable with, please bring the baby to the hospital. Nobody should deceive you that, oh, my grandchild or this uncle of yours had the same eyes and I kept the child in the house for nothing happened to the child. Please, so far as you see something that looks yellow in the child's eyes or you're not sure, please rush the baby to the hospital as soon as possible. So thank you very much for the questions and the answer session. So I think we'll move on to the video challenge lunch. So I'll ask Dr. Bright Daniel to take over, please. Thank you. Bright.
Hello, thank you, Francis. Thank you, Team Eastern Region. My name is Dr. Daniel Richard Bright. I am privileged to be launching the Newborn Jaundice Video Challenge. I want to say a big thank you to all those who have worked behind the scenes to make this challenge. That will make the challenge a success. First of all, as part of our Newborn Jaundice Awareness Month, we are inviting the general public. The key word here is the general public. This challenge is not open to health workers. So we are inviting the general public to submit a 1-minute video. You have to submit a 1-minute video. You have to submit a 1-minute video showing yourself advising a pregnant woman about newborn jaundice and the signs that should prompt that woman to immediately report to a health facility for care. Let's take note that today's video could be in English or any other Ghanaian local language. Once you are done with your video, you can send it to the Newborn Jaundice Video Challenge Committee on this WhatsApp line, 020 77 61902. Again, 020 77 61902. You are kindly encouraged to send a message alongside. The message alongside your video should indicate your name, your age, your occupation, your contact number, the town, district, and region that you are posting the video from, and then the language that you used in the video. Let's take note that there are exciting awards for the best 3 videos in Ghanaian, made in Ghanaian language category, and then the best 3 videos made in English. Also note that the videos, once you enter this video, whether you are a winner or not, these videos can be co-opted for use by the Pediatric Society of Ghana solely for health education. And this can be done without prior notice to you as an entrant. Winners of this challenge will be announced at the National Stakeholders Meeting that will be held on the 28th of May, 2021. So again, the key message here is that our eligibility is for non-health workers. Please submit a 1-minute video showing yourself advising a pregnant woman about newborn jaundice and then the signs that should prompt immediate reporting to a health facility. So once again, we want to thank Pediatric Society of Ghana. It's going to be an amazing month as we drive this yellow month forward together. We will be sharing the posters around. We are having highly qualified judges to determine the winners of this challenge. We'll be counting on your entries to make this challenge a success. So on that note, we declare the Neonatal Jaundice Video Challenge duly launched. Thank you.
Thank you very much, Bright. Dr. Jennifer, please take over, please.
Hello. Okay, so we will now invite Dr. Pabi to lead us in our Jaundice pledge. Hello. Hello.
Yeah, hello, yes, hello.
Hello, yes, thank you very much. Can I be allowed to share the pledge, or somebody will share for me?
Thank you.
And may I please advise that we put our videos on?
Okay. Which one? Like, let me see the video.
Okay. Do we all have our videos on?
Yay.
Yes.
Okay.
Yes.
And we can see the pledge?
Yay.
Okay. So with our right hand on our chest,
yes,
and standing up if
I think it's
possible.
yes. Yes, please.
And standing up if possible. Can you please say the pledge after me? You mention your name.
I,
Dr. Pabi. Pledge to support efforts.
I, Francis Mensah,
to reduce brain damage.
Brain damage.
And death from neonatal jaundice.
To reduce brain
Jaundice.
I know that I have a role to play.
I know that I have a role to play.
And will do all that is within my power.
And will do all that is within my power.
To ensure that no baby suffers.
To ensure that no baby suffers
from preventable disability or death.
From preventable
disability or death.
Caused by newborn jaundice.
Caused by newborn jaundice.
Under my watch.
Under my watch. I am deeply convinced.
I am deeply convinced
that I am an essential part of the solution.
That I am an essential part of the solution.
I will constantly upgrade my knowledge.
Constantly upgrade my knowledge.
To the benefit of these newborns.
The benefit of these newborns.
The benefits of the newborns.
I am determined to play my role.
I am determined to play my role
in educating the public.
Educating the public.
I'm determined to play my role.
About newborns and jaundice.
About newborns and jaundice.
I will advocate for good laboratory services.
I will advocate for good laboratory services.
And phototherapy equipment for health facilities.
And phototherapy equipment for health facilities.
I will promptly refer babies.
I will promptly refer babies
who may require specialist care
Who may require specialist care
for newborn jaundice.
for newborn jaundice.
Our babies will thrive
Require specialist
Our
care.
babies will thrive
as I consistently fight for them.
as I consistently fight
Fight.
for them.
I know our newborns are counting on me.
I know our newborns counting on me.
I will not disappoint them.
I will not disappoint them.
I will not disappoint.
So help me, God.
So help me, God.
Amen. May God help us all. Thank you.
Amen. Thank you.
Amen. Bless you too.
Over to you, Francis Yanifua.
Amen. Thank you very much. Thank you very much. I think we. Okay, thank you very much for the pledge. If I can, closing remarks.
Yes.
Please, you may all mute your mics.
Hello. Can we mute ourselves now?
Okay, so
Mute ourselves.
on the hospital, everybody.
Okay.
So we would like to thank everyone. Hello, Francis.
Hello, yes. Yes, please.
Yes. All right. So we would like to thank everybody for making it. We had a good number of participants. We had after the time we are closing, we had 92 participants. We thank every one of you for coming. There will be follow-up educational sessions during the month. So we'll get more opportunity to ask a lot more questions and learn. Thank you so much. We hope that you, as you go back to your various facilities, you'll be advocating for the baby with jaundice. You'll be advocating to get a lot more equipment to treat them as they come in. We thank God for bringing this meeting to a successful end. We thank God that this meeting was made possible in the first place. We thank the national executives. They've been amazing program in getting everyone to get to do something. Every single one of us. We thank the national executives. Then the Regional Pediatric Society executive. I say, you've done so well. You've been amazing. And our pediatric nurses, our nurses in the region, all those who have been working behind the scenes to make this program a success. We thank you very, very, very much. Dr. Panga, Dr. We are very, very grateful to you all. And then for the Newborn Jaundice Awareness Month Committee, thank you so much for making this year jaundice lunch and everything amazing. The energy is commendable. I mean, day in, day out, every night, there are various discussions helping us to channel everything and make it very, very well. Thank you so much. And for Eastern Region, all nurses, all midwives, all our team members, I say are equal to everybody for making this program a success. We'll be bringing our pictures very soon. And I know that this year we are winning. Even for the video competition, Eastern Region is going to win. We are going to bring the videos. We are going to bring the pictures. Our decor is on point. Thank you all. And I know that there'll be no challenger, not even Northern Region. Thank you for coming.
Thank you very much. Thank you all, and God bless.
Thank you, Eastern Region.
So enjoy the rest of
yes, please, we'll leave the last note for Dr. For our pediatric nurse, Delali, she's our vice president, to give a few remarks.
Okay. Delali, please take over.
Hello, Delali. Hello, Dela. Hello.
I think she on.
I think maybe her network.
Yeah.
Yes.
I think she had a problem with her internet.
Oh, okay. All right. So thank you all for coming. Thank you.
Okay, thank you. And sorry if you've not answered all your questions. Thank you very much.